Um, so thank you again for joining us today as we're talking about access for all, delivering disability inclusive dental care in rural communities. We can go ahead and go to our next slide. So I am Liz Flannery. I'm the Director of Education and Leadership here at the American Institute of Dental Public Health. I'm really thrilled to be with all of you here today and see some familiar faces. I'm going to give us a quick intro and some housekeeping pieces, and then I'm going to hand it over to Dr. Nick Rogers as he gives us our didactic presentation here today. And as always, we are going to have time for Q&A and community discussion. We invite you to stay interactive, and if things occur to you as we're going through the presentation, please post those in the chat and we can pause or we can make sure we capture those at the end during our discussion time as well. We can go ahead to the next slide. We want to say thank you to our partners on this work. This is our 4th year doing a rural oral health seminar series. For those of you who are live, we will have links at the end of this session to our CEUs, which also has all of our past programming that you can review asynchronously. And if you are viewing this asynchronously, you are already in the Academy and can click through to those past seminars as well in that space. You can head to the next slide. This session is being recorded. Please stay muted until we are having our group discussion time. All of our session materials will be available on our Academy. Please be respectful and avoid PHI or PII in this session. We invite you to type your name, your organization, and say hello to fellow participants in the chat. We strive for interaction and connection, so if you want to share your work and connect with your colleagues in the chat, we invite you to do so. If you have any questions about Zoom, you can ask a team member in the chat. We have Rahel Michael here from our staff, as well as Shayla Stewart. They are on tap to help with any troubleshooting. Hi, Christina. Hi, Brenna. We can go ahead to the next slide. So a little bit about AIDPH, who we are and why we're doing this seminar. Our mission is to empower our community to advance oral health through science, education, and advocacy. And we do this work because we have a vision of a justice-oriented oral health system. So we're really looking forward to those folks in your community hearing from Dr. Rogers today and gleaning some lessons learned that hopefully you can bring back into the work that you are doing to advance oral health. We can head to the next slide. We have 4 communities of focus at AIDPH. That includes LGBTQIA+ people, veterans, people with disabilities, and people living in rural communities. And if we go to the next slide, we of course recognize that there's intersectionality among these communities of focus. Today, this seminar series is focusing on rural communities, and we'll have an understanding that, of course, our other communities live in rural communities as well, and we'll hear about that intersection of people living with disabilities living in rural communities. Can head to the next slide. This is a little bit about AIDPH and our educational offerings. I mentioned that this content lives in and will be housed in our Academy, which is our digital learning space. Some of you are watching this live now, and some of you are watching this afterwards asynchronously in the Academy space. We will share links and instructions on how to get to that space afterwards, which is where you can request your CEUs and again, review past seminars for CEU and education as well. Can head to the next slide. These are our session norms. Again, we have time built in for discussion, Q&A. We want folks to connect in the chat. And as we do so, we want to ensure that we're having a respectful and collegial environment. So we want to make sure that we're respectful of the idea that everyone learns and everyone teaches. We use first names to facilitate equality in the discussion. We invite you to add your pronouns to your Zoom name. Introduce yourself during our discussions, and if you are able, please turn on your video and stay muted so that you're here and present during the conversation. You can head to the next slide. So this seminar is part of a series that we are doing throughout 2025. Again, if you are in the Academy space, you'll see the previous seminars that we have done so far this year. We have talked about veterans in rural communities. We've talked about workforce development strategies. For rural communities. And today we are talking about delivering clinical care to people with disabilities in rural communities. Our theme for this year, building off of our colloquium theme, is dental care is a human right for rural communities. There are CEUs offered for each session, and at the end of the series, after November of this year, there will be a certificate available for advancing oral health justice in rural communities if you complete all 5 sessions and a competency quiz at the end of them. We can head to the next slide. This is a disclosure that our presenter, Nick Rogers, does not have any disclosures or conflicts of interest to share with us. Can head to the next slide. So without further ado, I'm going to hand it off to Dr. Nick Rogers, who is a general dentist in Arkansas City, Kansas, a rural area of South Central Kansas. He's an affiliate member of the American Academy of Pediatric Dentistry, having served on their board of trustees and a recipient of the Merle C. Hunter Leadership Award. He completed the Kellogg School of Management Leadership Institute and the Wharton Leadership Institute. He is an active member of the Kansas Dental Association and has served as president for the group being selected as their Dentist of the Year in 2011. He has many accolades in his career, and I will hand it off to him to share more about that and really go into detail of the work that he has done, ensuring that people with disabilities in his community are receiving access to dental care. Thank you so much, Nick, for being with us here today.
Well, thank you, Liz, for that kind introduction, and thank all of you for being here. I hope I have something that's important to share that you can take away with you, but it's more my story of how I got here. And I am a general dentist, as Liz said. I've practiced in this small rural South Central Kansas community since 1979, and those of us in Kansas call it our Kansas City, but you're right. It's right where our town is, right where the Arkansas River goes across the Kansas-Oklahoma border. Of course, when it goes into Oklahoma, it's the Arkansas River again, so it's all good. But at any rate, my head's. I think the next slide is my introductory slide, is it not? If you change slides there. Well, it's not, but the title slide I had in my pack was A Dental Home for Everyone. And I like that slide because that's what it would have been before the objective. So you're fine. You can just leave it there. Um, um, it kind of describes what I've tried to do in my practice, and I think I've done it well. And that is, I try to identify the needs of my community, garnish the skills and the partnerships it takes to meet those needs, and then try to figure out some way how to make a living doing it. I chose this. I was not from Arkansas City originally. Upon graduation, my wife and I chose this town. We actually just stumbled across on the way back from a Christmas visit to her parents in Dallas, Texas. We wanted a small rural town because we wanted to experience that sense of community. Growing up, both of us moved around a lot, and we wanted a small community so we could feel that, have our kids raised in one place and know our neighbors. And I guess I sort of had a Marcus Welby type practice in mind, or Ozzie and Harriet type lifestyle. And I know 90% of you are going to have to Google that analogy, but at any rate, it refers to a small rural physician's practice. Our practice does serve two disproportionately large populations that in general have trouble or challenges accessing dental care. One are children on Medicaid, specifically small children. Our schools, we're a low social economic community, and our school system has about 70% of its children on free and reduced lunches, which means there's a similar percentage on Medicaid cards. And so our office is completely open for children under the age of 21 years of age with medical cards. We accept them all. The other population that is disproportionately large for general practice is we have a lot of people we serve with disabilities. And this is primarily due to in our county housed one of the state hospitals until 1998 when it was closed, a hospital for some of the most severely mentally and physically disabled people in the state. It was closed in 1998 as a result of the 1995 Kansas Disabilities Act. Now, when they were in the hospital facility, they had a full-time physician and a full-time dentist that could meet their needs. And if they needed care, they could coordinate their treatment and do it under all one sedation and one general anesthetic. Uh, when the hospital closed, the financial resources were supposed to follow these patients out into the community, but I'm not sure it did a very good job of that. The slide is where we are right now. This shows I practice with my son, my daughter-in-law, who's a dentist, a new associate, and myself. And just in general, when you're seeing a lot of people with disabilities, you generally have to spend a lot more time with them. And if they're on a medical card, you're kind of spending twice as much time for half the amount of money. And so to keep the office overhead met, I'm fortunate that I work with three other dentists that can kind of meet the overhead needs of the office while I take care of the special needs patient. And I'm implying I'm the only one that does that, and that's not true. My son, they all see the special needs patients to some degree. Next slide. Yeah, next slide there. And where I am located, as I said, is in south central Kansas, right on the Oklahoma border, right where the Arkansas River crosses the Kansas-Oklahoma line. The closest specialists are a little over an hour away in Wichita, Kansas. We have Tulsa's about, just a little under 2 hours away. Oklahoma City, just a little over 2 hours away. And Kansas City is about 3.5 hours away. So we are very rural. Our Kansas geographically is one of the larger counties of the state, but the total population is about 35,000. Our community is about 12,500, and our sister city, about 10 miles to the north, is a little under, probably about 11,000. And the rest of the communities in our county are probably anywhere from a little under 500 people to 1,000 people. So we're very rural. The next slide, please. The question is, why do I see people with disabilities, or why do I see these children for that matter, when you're not making as much money, it's taking more time? And one of it is what I alluded to earlier, the sense of community. I mean, these people, they're my neighbors, they're a part of who I am. And particularly the children, I sit next to them in church. I see their parents in the grocery store. They're my kids, now my grandkids' best friends. And the special needs population, or the people with disabilities are the same way. So they are part of who I am. I feel some responsibility. Probably everybody on this call either has a relative or a friend or somebody that has or knows a person very close that has some disabilities. And I had a cousin that was my age. She was disabled, and she died at a very early age. So I feel some responsibility just because I made a commitment upon graduation from middle school. I would do my best to meet the needs of this population. And also, so I feel some social and professional responsibility. Society gave me this ticket called a dental license to do dentistry, and I feel like I owe it to society to give something back. So those are the main reasons why I see this population. Plus, if you'll change the next slide, they're absolutely a delight to see. Some of these people, the two people pictured in this picture, have been patients. The young lady on the left, ever since she was her first visit to the dental office was in our office. She's now in her mid-30s. And the gentleman on the right's a regular patient. And when they come in the office, we don't see a disabled person. We just see a person with a specific personality, and they're really fun. And you get to know them. You're a part of their lives. And they're a part of our lives as well. Next slide, please. The key words in treating people with disabilities is I'm going to go into this in a little more detail on, but communication. And I should have put communication in advance, but it's so important to communicate with people to find, well, we'll talk about that in a minute, but communication is one of the key words. You know, uh, we have a lot of empathy and we really do care for them. but we really don't feel sorry for them. This population, I'm talking like I'm one of them, I don't know, but I don't think they want to be felt sorry for, at least most of them. But you have to be empathetic and caring, not feeling sorry for them. Adaptability for sure is a key word, and then we'll talk a little more about that. You have to be adaptable, change at a moment, because the treatment doesn't always go as planned sometimes. And regardless of what name you give people with disabilities, even the children we see, they all take special care. So it's a special care type of a patient, is how we look at it. So if you'll flip the slide there. One of the key words is being adaptable. First of all, you kind of, when they come into the appointment, you kind of know what is it that what is a primary thing we want to get out of this appointment. And that's what we try for. And anything else is a bonus. Sometimes you start off an appointment and you may be doing a restoration on a patient. Well, they may have had a bad day or things don't go quite as good. And sometimes some of the procedures we use are really technique sensitive. And if you know you're not going to get that cooperation for a technique sensitive procedure, then you automatically get what other kind of material can I use that will still serve the purpose, may not be quite as good, but yet gets the job done. You may have to cut your appointments short sometimes. Many of the special needs patients that we see in the office, we know we're not, or the people with disabilities, we know we're not going to get everything done. We're not going to, when they come in for their 6 months recall, we know we might not be able to do as thorough of cleaning as we can on a traditional patient. But if we can keep them going for maybe 2, 3, or 4 years, monitoring them and doing the best we can, then we can either use sedation or general anesthesia in the hospital to sort of catch them up and start the cycle over again. Finding solutions. I put that with critical thinking. Dental school, we're taught to make these perfect preparations within a tenth of a millimeter. And, when you're dealing with children or people with disabilities, I would contend sometimes a tenth of a second is far more valuable than a tenth of a millimeter. And in dental school, they taught us how to do all these perfect procedures. But at least when I was in school, they really didn't do a very good job of teaching me, okay, I've got this person that I have to work around within these parameters. I only have this much income to work with. I only have these materials to use. What is the best treatment I can give to this person? And they also kind of teach you in dental school, if you don't do that very best preparation within a tenth of a millimeter, you're not a good dentist. And it took a long time to get over that sense of guilt in treating both children and people with disabilities, to know that, yeah, they're on a person without any disabilities, yeah, I could have done that a lot better. But this is the best I could do on this person, and they have maintained their health and they keep going. But it takes a little bit of out of your training to get the mindset that you're still okay if you don't get the perfect restoration every time. Next slide. Um, Another thing, that first bullet point is more for me than for anybody with disabilities. I was a disabled person on this particular one. Appearance is deceiving, and when you see a person come in your office, don't prejudge them. I know this was quite a few years ago. A gentleman came in a wheelchair, and he was kind of physically disabled, kind of hunched over. And I started talking to him. And after a few sentences, he looked up at me and says, "Why are you talking to me using baby talk? I'm not stupid. I'm disabled, but I'm not stupid." And then I looked at his hand, he was reading a novel. So, you can't prejudge him and you can't, yeah, you just have to talk to all the special needs patients, or I apologize for using that, people with disabilities, just as if they're a normal patient. One thing I've learned on the second bullet point: parents and guardians' love and concern. I'll tell a story when the slide comes up later, but these parents, it's amazing the love. I mean, that's a terrible way of phrasing it, but it's hard to measure that love the parents have for these young people they're treating for with disabilities. I think they do everything in their power to make it make their lives normal. And part of that is the dental work they think is possible. And one of the hardest things for me to do is have that conversation with the patient and the parents about, well, now to put that implant in, it takes many long, multiple appointments. And I just don't think that's going to be possible. Probably one of the hardest things I deal with is when I have a front tooth and it's not restorable. And the parents always want to replace it. And, a lot of patients, due to their sensitivities, cannot tolerate or won't tolerate sensitivities, won't tolerate a removable appliance. And that's assuming they even have the physical ability to get it in and out. And trying to find a solution for that is really difficult for me. And when I have to do something that's cosmetically um, hurts the cosmetic appearance of them for their health, I struggle with that. I struggle with what's the best thing to do. And the easiest, and like I said, communicate and educate. We have to sit down and talk about what the possibilities. I tell them all the possibilities out there. I give them my opinion of what is probably possible and what's not possible at all. And then we sort of make a shared decision on what we're going to do. And I will have to admit, there have been times that I've told a parent, it's just they won't adapt to it, and I've been wrong, and they have. So I'm willing to usually bend my judgment sometimes. I know on that first slide we saw the young lady sitting in our orthodontics. Her parents really wanted, she had Down syndrome amongst many other diagnoses. And she had so many sensory issues, but her parents wanted her to have a perfect smile. They wanted orthodontic treatment. And that was the lady that was sitting with her was our orthodontic assistant. And she was so good. She worked with her very patiently for about 2.5 years. And we finally accomplished orthodontic treatment. And so, again, don't prejudge. Have an open communication with the parents and the patients, and then come to a conclusion on what you're going to do. Next slide, please. The patients that we serve with disabilities most of them are patients in our community, patients that we've known that have been a part of our practice for years. And like that one picture showed, they're just a part of, we don't even see them as people with disabilities. Because of the closure of the hospital, there's many group homes, but not only within our community, but for that matter, all over the state that take care of people with disabilities. So we have a lot of people from group homes, not only within our community, we service them probably within about a 2-hour radius of my community. Around the Wichita area, there are several group homes that'll bring the patients down here. Most of those we are able to treat within our dental office. We have shared patients. By that, the nearest children's hospital is in Kansas City, 3.5 hours away. And they're primary physicians, and their primary treatment is done up there, but we do their dental work in consultation with Children's Mercy in Kansas City. And they're patients, for the most part, that live within our community also. Then we have actually a growing number of referred patients. Most of the referred patients we have are from far away. They have to have their dental work completed in the hospital under general anesthetic. And those are the ones that take the most communication for, and we'll talk about that a little bit more in a lot. But we do have a large number that the furthest patients we see are about 5.5 hours away that require general anesthetic, because there's not a dentist that we know of in at least in the central part of Kansas that has number one hospital privilege, and number two is willing to see the population. Next slides, please. Next slide, please. So the golden rule, if you're seeing one special healthcare needs patient, one person with disabilities, you've only seen one person with disabilities. Each person is unique with unique needs, behaviors, and even if they have a similar healthcare needs diagnosis. For instance, autism is a spectrum. Some autistic kids, you hardly know they have a diagnosis, whereas others, you can't even get within 5 feet of them. So and furthermore, it's complicated by so many of these people with disabilities. It's not a single diagnosis. They have multiple diagnoses. They have medical or medication lists that are like a foot long, and each has a different personality anyway. So it's hard to make a how to do it book for an autistic patient because they're all different. It's hard to do a how to do it book for a cerebral palsy patient because they're all different. Each is very unique. Next slide, please. Like I said, the key is to get as much information as possible before the appointment. And I emphasize before the appointment. We need to find out a little bit about this person. We need to know how to schedule them, what sensitivities they have, so they might be avoided. And so we always try to consult with the patient or the guardian, or whoever's bringing them in, or whoever's responsible for them in advance. Um, we always listen carefully to the management concerns and management of the patients. The parents or the guardians are usually right. The only problem challenges we sometimes have are sometimes patients coming in from the group homes. They have a driver that brings them in, but the driver is not the guardian. In fact, some of these patients, we've never met the guardian or parent. And that's kind of hard. You ask the drivers about some of the sensitivities, and they know nothing about the patient particularly. They're just the driver that's brought them in. And so we try to have those conversations in advance. And furthermore, I say you must communicate in terms that the family can understand. I try to avoid complicated terms. I'm kind of a simple guy anyway, so it's easy for me to talk and use more common language. And another thing it's not a bullet point here, but you have to remember some of these people with disabilities are their own guardian, or that they have their own oh, I lost the term, but they make their own choices. So you have to talk to them as well. But having communication in advance helps you in the schedule, helps with staff readiness. And if you'll do the next slide, for years when we got these particularly patients that were coming from afar that needed general anesthetic and anesthetic general anesthesia for their dental treatment, in dental school, we're taught never to treat somebody without seeing them first. Well, if they live 5 hours away and you're told they're not going to open their mouth for you anyway, why make them drive 5 hours? Just go, you're right. So you try to put a picture of what this patient is like before they come in. And for years, I had this it was sort of a liquid list of questions. We always fired out to them, and usually almost every other time we go, oh man, we forgot to ask that. So we'd add that to the list. And finally, Oral Health Kansas, with a CareQuest Foundation grant, came up with this dental care passport. And it really, that's what we use all the time now. You can find it online. You can Google Oral Health Kansas Dental Care Passport, My Dental Care Passport, and it'll come up. It's both in Spanish and in English. But it really asks all the questions. I'm looking at it. It asks about questions like the personal data, medical history, dental history, um, about the sensitivities. Are they mobile? It asks and what communication techniques do you use? And it answers all the questions you really need to know. If we know that they're going to be a hospital case, we always ask for the latest history and physical because we have to consult with our anesthesia team as well. But for those people that travel far, and we use this on even our local patients, our local community that we can see in the office, that we know we can perform all the dental treatment they need in the office. We still need to know what their sensitivities are, how to communicate with them, and so we don't use any trigger points. Um, I know one time, this is one time, when you're working on kids, you go, this is a little garden hose we're going to use to rinse your teeth, or this is a little bumpy, and we use for the suction. We said, well, this is like the little vacuum, and we didn't know that term vacuum triggered a person, and we lost that person. That appointment was lost right there because we used that term vacuum. So you need to know those in advance. Next slide, please. So for scheduling, one of the things we're trying to garnish from that dental care passport is, are they going to need a familiarization visit? And if so, how many? Um, Our loud noise is going to make them sensitive. So when they schedule, most patients we schedule that have noise sensitivities or are overstimulated easily, we make sure they're scheduled so they bypass our reception room and go right to the treatment room. Our office is well, with four dentists and a lot of little kids, it's chaotic to say the least, and it's not conducive to many people's disabilities. So we try to get them right to we try to make sure that they're scheduled on time and we can get them back there on time to avoid the waiting room. Um, examination process. At school, you're taught how to do it just perfectly. I mean, I've done some examinations in the backseat of a car in the parking lot because, the patient won't come in. So the examination process isn't always ideal. But if you have this information in advance, again, you know what the primary concern is. If it's pain, you try to you try, that's what you're looking for primarily, and so you try to eliminate or find out what the cause is. And also treatment time. It doesn't need to be extended. This gentleman on the right, the picture you see, that is not our equipment. He has Asperger's. He's a very bright individual, but he knows his limitations. He has to be tightly wrapped. Uh, he has to be very securely bound to feel comfortable for dental treatment. And he's probably 6'6" and he comes in the office every appointment carrying his 6 foot long papoose board with all these new bindings. He always gets excited when he finds some new type of bindings he's found somewhere. And I'm always wondering what the people in the reception room think as he walks through. But at any rate, this is part of the joys of seeing people with disabilities. But you can see it takes extra time to put all that stuff on. So the hygienist takes the schedules a little extra time. And the logistics for treating them. Uh, are they in a wheelchair? When I built my office, number one, I made sure it was ADA compliant. When we put our operatories in, we have a fairly open office, but I made sure that the entrances were wide enough to get a wheelchair in. So you'll see some slides here in a little bit where we're treating people. They're just still in the wheelchair. Some of those wheelchairs, as all of you know, kind of tilt back anyway. It makes it a little easier. Some do not. But we do a lot of treatment just sometimes when they're sitting in the wheelchair. And again, what kind of adjunctive techniques are we going to use? We have one room. Let me see if it's the next. Well, I'll get to it. We have one room that's a little quieter, but we do have the weighted blankets. We have the noise canceling headphones. We have, and I'll talk about the one room we have set up for just highly sensory patients. Next slide, please. Team effort. It does take a team to make all of this happen. And every morning we have a huddle like most dental practices do, whether you see special needs or people with disabilities or not. But over that, we have one person in the office that's assigned to the sedation hospital cases and most of the people with disabilities. And she can say, so and so's coming in today, and she reminds everybody. She usually sees Tony as the hygienist. The assistant that usually works with them is this assistant, and so we try to keep them with the same people every time, and we try to tell the whole staff because the front office has to know too. Because is this a patient we're trying to get right back to the reception room immediately? And even if the operatory that they need to be in isn't open, we'll get them back there to avoid the noise really fast. And it's also important that your whole team, you go to the next slide, it's also important that your whole team treats these people with respect, both the Medicaid kids and people with disabilities, because if one of them doesn't understand, they can ruin the whole show. So we all work together. It's kind of hard to coordinate. This is our full-time staff. I think we have 10 assistants, 4 hygienists, and 3 front office people. There's some other part-time people that come in, but we all work really, really well together. One thing I've been blessed with over the years, I've had very little turnover. My assistant that just retired, we worked there for 38 years. So we've had a lot of time to build this team. And I think the culture is fairly infused within the team. The next slide, please. Referral source accuracy. One of the problems you have is how accurate is this person when they make the appointment? How accurate is this information? when it comes from a caregiver or one of the homes, it's not, I found out it's not always as accurate, or the stories aren't always as accurate as they turn out to be. And that's one of the reasons I use my dental care passport. We try to, if it's a facility, we try to talk to their guardians or legal guardians if possible, if they're active in their lives. We get a lot from, there's an excellent safety net clinic in Wichita called Grace Med, and they refer a lot of those that need sedation and general anesthetic, they refer to our office. And we've worked with that FQHC on a lot of other projects as well. We get a lot of referrals from them. They're sometimes their information is coming from a dentist that just recently graduated from school, and they haven't had much experience treating people with disabilities. So there have been quite a few occasions where they say they need sedation to be treated. And once they get here, they do fine in a regular setting, or at least for some of the more simple procedures. So there have been times we have avoided surgery. I love getting referrals from pediatric dentists because they give you the most accurate information, all that you need. Pediatric dentistry is the only specialty, the only people that really trained for people with disabilities. That's part of their training, and so they get it. And I love, and truthfully, they're so good at it too because the same techniques used for kids work well for most people with disabilities. So they're very good at treating that population. The only problem is when they become adults and have adult needs, they don't have the techniques or the equipment to do that. And we get many from the physicians, and I know from physicians, they can give you a great, accurate medical diagnosis, but they know about zero about oral health. So you always have to take that into consideration. The next slide, please. We have the three different places we treat people with disabilities. By far, we treat most in our just our regular traditional office setting. We have a CRNA that comes in and does in-office sedation. We'll line up a day where we just do a bunch, and that's really good for like younger, mildly autistic patients who can't, the sensory issues, or somebody that's really has some serious sensory issues, and they're ASA1, which means they're fairly healthy patients. And then we have the hospital. The next slide. The advantages of, and this is Joe. Joe, every time he comes in, he asks, "How's your mother doing?" Now, my mother's been deceased for probably 20 years, but I always talk about my mom, and he always has a conversation about sports, and he's a delight. But bottom line is, he's been a patient forever. But eventually, doing your own office, first of all, it's absolutely the safest. It doesn't disrupt the whole day. When we do sedation cases, one dentist, that's all they do all day. So they don't do any other production than that. And it's the most cost effective too, if you can see them in your own office. The next slide, please. This is the room I started to tell about. This is our sensory room. We have one room with a door that we can have, that would make it quiet. Yeah, I think maybe in the middle side you see the TV on the ceiling. We have weighted stuffed animals. We have weighted blankets for some of those that, particularly autistic patients. And quite frankly, there's a lot of other patients that feel more comfortable with it. We have we turn the lights out. You can see back in the left-hand corner in the middle slide, we have this mild oscillating light that kind of gently goes around the room. And again, for those that are even bothered by the noise of the hand pieces or some of the equipment we use, we have sound canceling headsets, if I can spit that out. But most of them have a headset on while they're watching TV. The TV is on a headset, which is a good distraction technique. The next slide, please. This shows our in-office sedation. The gentleman on the right is a CRNA that comes into the office. Now, different states have different laws with the use of CRNAs. In Kansas, they can practice independently. And quite frankly, there wouldn't be a rural hospital in Kansas that would have an anesthesiologist. You just can't afford to have them out there. So all your hospitals in rural Kansas are pretty much CRNAs. But the nice thing about doing an office sedation is it's less disruptive. You've got all your radiographic equipment. If you run into a case where maybe it needs a root canal that you didn't expect, you've got all the stuff right there in your office. You can just go ahead and do it. And it offers a lot of flexibility within the treatment. And the next slide. Whoops, I'm sorry, I lost. There I go. The next slide, that's actually the room next to the ones you just saw. The picture on the left is in that room, and that's the assistant I worked with for 38 years. And the one on the left is a recovery room. And that little doorway or that little opening behind her, the CRNA is just right on the other side of that. We keep monitoring equipment on the patient, and Billy, the person who really coordinates all the hospital sedation, spatial or people with disability cases. She's the one that's had training to monitor them, and if there's any problem at all, she just bends over and looks at the CRNA, and he comes over and helps. We've never had a problem with that at all. So the next slide, please. And then, of course, there's general anesthesia in a hospital setting. And when we do this, I alluded to the fact earlier that when they're in the state hospital, they try to coordinate as much treatment as possible. And for those around us where we know the physicians, we try to do the same. I was working on teeth and they were cleaning out ears, and we do blood tests for the patients while they're we've had tumors removal, we've had gynecological work on one end while I'm doing the other end. So we try to coordinate as much treatment as we can when they're there. Now, if you'll do the next slide there. Thank you. The two hospitals we use, go back a slide. I want to tell that story. I'm running out of time, but I have to tell a story. You can't see the face of that person, but his name was Gage. Gage had Lowe's disease. And Lowe's is one of those multiple, I'd look it up. I'd never heard of Lowe's disease. And you have to look, find out what are the dental implications, what are the medical implications. But in essence, they never grow. They never develop much past a 3 or 4 year old child. And they're short in stature. Their limiting factor is their kidney. They usually have kidney disease, and they usually succumb to it in their early 20s. And Gage's dad grew up in my practice. He said, "Hey Nick, would you see our son? He's getting ready to have surgery, and we need to get all his dental work taken care of in advance." I said, "Sure, we can arrange that." And when I went in for the pre-consult, when I went into the room to talk to his mom, he was curled up in his lap, just like you'd expect a 4-year-old to be. And at this stage, he was about 20 years old. He was curled up in her lap. And I got to talking, and I said, "Well, what surgery does he have coming up?" And I'm sorry, I almost get teary-eyed every time I tell the story. She said, his kidneys are failing, and I'm going to give him one of my kidneys. And I thought, wow, talk about, and it really makes you question yourself. Would I do that? You know what I mean? And she knows it will probably only give him maybe 10, 15 more years, but she was willing to sacrifice a kidney for her son with disabilities. And that story sticks with me. You go to the next slide. I just always have to tell that because it really makes me question my own social choices. But anyway, we work in two separate hospitals. They're both rural hospitals, both going broke or both with financial struggles. The one that's closest to our Kansas City is this one. And it used to be an acute care hospital, but due to financial changes, it changed its designation to a rural emergency hospital to survive. When it did that, it lost a lot of the support systems it had. So go to the next slide. So I got privileges in Winfield, the next hospital, and they're a critical care or critical access hospital, and so they have quite a few. They're able to see some of more delicate patients that I see. So we do surgeries there once a month, and then on in our city once a month as well. They alternate. One's on a Thursday, one's on a Friday. Next slide. Uh, Hospital. Now, as I alluded to, both hospitals are struggling financially. They have no dental equipment. So to do this, I bring my own dental equipment. I keep one, what we call cart, or the machine that runs the hand pieces. I bought one for each hospital and just keep that there. But all the other stuff, I just pack up, or the assistants pack it up, and I get up at 5:30 in the morning, run by the office, put it in the back of my pickup, and haul it in there. All the disposable supplies and any of the equipment we might think we need. If we think we might have to do a root canal, we take all that stuff. But they just don't have the resources to furnish that for me. And the next slide. This is a room. Those black cases, the red ones replace the black one. You can see us just setting up for one of the cases. And one of the problems, and this is not a rural problem, is probably even more so a problem in a big city, is that hospitals are reluctant to give up their surgery rooms for dental procedures because until about a couple of years ago, if you're doing a dental procedure in a hospital, the hospital got zero facility fees. And for the time it takes me to do one, one hospital case, they can probably, an ENT can probably run 20 kids through there. And plus the reimbursement is pretty good to the hospital. I mean, that was changed a few years ago, but it's still the reimbursement for the hospital is low. They can make more money doing other procedures if they're booked. So actually, for a dentist to get hospital privileges or time in a surgery room is becoming quite challenging. The other thing about doing hospital cases, before my kids came back from my office crew, I always did them. I still, for that matter, do them on my day off, because the most you can see on a hospital day are three or four if they're really simple procedures. But the only challenge is you've got people coming from 5 hours away. You have no idea what they really need. And some of those cases are like 3.5, 4 hour cases. So if we've never seen the patient before, we're basically just seeing two a day because we don't know what we're getting into. And it's because of that, it's really hard for a dentist. You can't shut down an office for a day just to see two patients, basically. And I'm just introducing that as one of the challenges from the dental side. Next slide, please. Um, the challenges for the dentist, I'll wrap this up, but I'm glad I got to this side. The challenges for a dentist seeing people with disabilities, I alluded to earlier. You said twice as much time for half the pay if they're on a medical card. And secondly, sometimes it takes multiple appointments to do an equal treatment, particularly if you're taking into account some desensitization visits, because there's no reimbursement for that. You just take time from your staff, take time out of the day to do that. Um, Staff buy-in is sometimes a problem. And like I said, the culture within our office, most of them have been around so long, they all buy into, they all accept what we do, what our mission is, and that's not really an issue. For some offices, it is. And it takes more staff time. It just takes more the paperwork. Billy's the person who does all the coordination from hospital sedation to new spatial or to people with disabilities. But she sometimes she'll spend hours on the phone just gathering, garnishing the paperwork needed to try to figure out what this person needs. If a person is going to do sedate, you have to build up some sedation source. You have to build up some usual partnerships, one with a firm that provides sedation services within your office. There's two in Kansas. The gentleman, the company that comes to my office comes from Lawrence, Kansas. It's about 3 hours away. And so we have to have a whole day just booked for him and to build that partnership. Um, Hospital privileges. As I said, I don't think I would probably, if I went to Wichita where they have a big hospital and a pediatric anesthesiologist, I don't think I would be able to get them, first of all, because of my credentials. I didn't go through any specialty program. And secondly, even if I had specialty, they just have told several of my friends who are pediatric dentists that we do not want dental cases. Time out of the office, I've alluded to that. You have to purchase extra equipment. I've alluded to that. Building partners with others. One thing I have a private practice, and if you looked at my list of partners, you would think I'm in public health. We work closely with not only the FQHC in Wichita, but we work closely. I was even on the committee that helped bring in FQHC to our community, and we provide their dental services for them. And school nurses and KDHE, we were part of their program for school checks. We do our county and the county to the west of us. So I built some unusual partners to try to meet the needs of the community. And your bottom line is you have to do all that without any extra reimbursement. And I say this because I get the comment, why don't every dentist see people with disabilities? And the problem is if you say, well, I'm willing to see the ones that aren't too badly disabled or I can treat in my office, but then your question is, what if I get one I can't treat? Where do I send them? Where do I go? And you have to have those partnerships as well. I know that over the time I've done these, there's been two or three that are just too sensitive for our local hospitals. We can't safely see them there. So I've got, if they're kids, it's no big deal at all. I've got a couple pediatric dentists in Wichita that, will easily see them. It's some of the adults are the hardest to find a home for if they're too medically complicated. But I see my time's kind of running short. I'll go to the next slide. I want to, oh, one thing about it, it really doesn't, you don't have to really learn any new procedures. I'll just say communication is critical. The next slide, it's a slide I always in my present, oh, resources. Um, the American Academy of Pediatric Dentistry. It's a great organization. It's mission driven. They really put those they serve above self. Having said that, that's where I turn to for all the knowledge I have. I have three individuals, one at Children's National Hospital in Washington, one at University of Washington in Seattle, and one at Columbus Children's Hospital in Ohio. Yeah, Shayla. And I turn to when I have a person with disabilities, I've never heard this diagnosis. I don't know how to treat them. I'll call them or text them or call them. And so I have those to lean on. Last slide for me. Well, next slide. Oh, if there are any dentists on the call, if there's anybody, there are resources out there where you can get some sort of weekend training. But this is sort of my model. So many people, it's from Tuesdays with Morrow. Mitch Albom's the author, but so many people walk around with meaningless life. They seem half asleep even when they're busy doing things they think are important. This is because they're chasing the wrong things. The way to get meaning into your life is devote yourself to loving others, devote yourself to your community around you, and devote yourself to creating something that gives you purpose and meaning. And rural dentistry has done that for me. So thanks. I'll open it up to questions. You can do the last slide because that's a shameless picture of my granddaughter.
Thank you so much, Nick.
Yeah.
That was a
I,
really wonderful presentation. Um, so yes, we would love to open it up for Q&A with our participants. If you have a question, I invite you to come off mute and share. I can kick us off. Um, like I said, this is a great presentation. I really appreciated your humility, sharing kind of maybe times that you learned from your patients and took a different approach. I also, I think I could really see this as kind of your life's work and how you have built networks to have colleagues to go to and those non-traditional partnerships that we talk in public health. Um, I wonder a couple of things. Do you have advice for students or folks who are early mid-career who want to pursue this but might not know how to build those networks or get started? Advice for them to kind of start down this path and stay in it the way that you have.
well, I would say, first of all, just jump in. I mean, be safe. I'm not saying go to take hospital cases, but start offering to open your practice up to some of those that you feel. Use that tool, that My Dental Care Passport, and read it over, look at it. And on there it tells them past dental experience, and you can get a pretty good idea if you can see them, and if you have them fill that out ahead of time and look at it. And look at their medical history too, and see what their past ill experiences have been. You'll be safe. And as far as building up, I mean, I've had. I'm ashamed to say I've had no special training in this, although I've gone to a lot of CE. Building up I don't want to plug any one organization, but really the American Academy of Pediatric Dentistry is a great place to go to for the resources. I mean, they're a giving group. They give away their knowledge, so that's a good place to get, and they accept general dentists as members too, by the way.
Fantastic.
Yeah.
A follow-up question to that, I think,
Yeah.
again, I see a lot of kind of self-taught, self-learning and kind of building a body of knowledge. So again, thank you for sharing your insights with our group here. Do you have um, a network or a group that you can kind of have these conversations with fellow clinicians, but also people who are, administrators, office folks, where you can kind of share success stories? Is that something that's part of how you approach and kind of keep track of all of the lessons learned?
Um, I don't really have a network. I mean, the network that I use to are probably pediatric dentists because they're really trained for that. When the only difference is between them and me is, I mean, they have more training. What I mean is they just lose the skills adult teeth need. You know what I mean? They don't have the equipment there. So if you have a good relationship with a pediatric dentist, that's a good place to start building team. But I don't have any group per se. There's one other dentist in Kansas City, 3.5 hours away. He and were friends beyond treating people with disabilities, but he and I talk quite a bit. And quite frankly, those within Oral Health Kansas, to put a plug in for that group, they do a marvelous job. And they do a marvelous job of helping you find resources too within Kansas. Yeah.
Okay, great. And I'm seeing that Abby put in the chat dental provider advisory group, and I'm taking that that's a resource that you're recommending, Abby, for folks to kind of network and share.
Yeah.
What was
Uh,
that? Oh,
yeah, so that Oral Health Kansas put together this dental advisory group, and it's just dentists that get together about once a month, and they just kind of do exactly what you were talking about, where they share different stories, different experiences, any resources that they might have that they've seen come in handy. So that's a good group to join into, and it's all virtual too.
and thank you,
Fantastic.
Abby.
Thank you.
I should have thought of that too. But Tanya asked if I want to be a part of it, but I've been so many of the other groups. I said, if you need me, I'll be there.
Yeah, you're a busy man, Dr. Nick Rogers.
Yeah, thank you so much, Abby. And good modeling for our all teach, all learn model here.
I
I
will
think
say,
Lenedra, oh,
oh,
sorry,
I
go
was
ahead.
going to say there is an association for, it's a combination of hospital dentistry, special needs dentistry, and there's one of the, I can't think of the group, there's a national group. I was a member of that, but I wasn't getting much out of it for me as far as how to do it Monday morning. You know what I mean? So I'm not an actor, but there's another group out there that can offer that as well. I'm sorry, Liz, interrupt.
No, not at all. Please don't. We have just a couple minutes and we are going to share out some CEU information, but I know Lenedra has a question here. And I think maybe we touched on it briefly, but it's a little bit about how challenging it was to build your referral system, specifically with FQHCs and other organizations.
Now, what's, are you talking to me, Liz? I don't think I understood the question. I apologize.
No, that's fine. Lenadra's just putting in the chat here asking how challenging was it to build your referral system with FQHCs, other organizations, and advice to start the conversation with FQHCs.
Well, for the FQHC part, I mean, that's kind of easy. I mean, that wasn't any problem at all. I prior to the one we have in our local community, I worked with Grace Med, which is in Wichita. It's a great organization. They have sort of a hub spoke model. They have offices, throughout the state, and we work together like on the school screening and checks and sealant program. And I think it's just because the reason I think what initially hooked us up with somebody at KDHE, Kansas Department of Health and Environment, just knew I sort of had a public health mind, and she said, I we've never done this with a private practice before. Would you be willing? And I said yes. And so Grace met, and we worked together and sort of splitting up the territory, so to speak. And also their dental director, she was running some challenges with not just only people with disabilities, but also some children that needed some special sedation or whatever. And so she'd call our office with some regularity too. And I didn't. And then when they were starting when it was recognized we really need a clinic down here because our underinsured or not insured, uninsured and underinsured population was so high, I was a part of that committee as well. So talking to the FQHCs. I also, one other thing that opened me up, in dental school, I got about this much, about zero. I mean, I heard the term public health. I really didn't understand it. I was a part of the what they call the American Academy of Pediatric Dentistry and Office of Head Start initiative a few years ago, where basically the academy said we can get all your Head Start kids into dental homes, and I was Region 7 oral health consultant for that. That was about the same time my kids came back, so could take some time off. And that experience, I had Iowa, Nebraska, Missouri, and Kansas. That really opened my blinders to what oral health was, what it was trying to do, and quite frankly, if I were 20 years younger, I'd go back and get my MPH. It really opened my eyes. So that was a great experience. So that's how I got public health. As far as um, just local partners, you just start digging, who can do this. I started doing only hospital dentistry, and it got to the point where it was hard to find hospital time just because I didn't have enough days off to do it. And somebody said, well, there's this guy that provides sedation. I was a little reluctant to do that, but he came in, and there was another dentist out in Western Kansas, out in Garden City, Kansas, actually, that said, you need to go help Nick Rogers. He's doing the same thing I am. And they just kind of, when you run into trouble and you start seeking and start talking, those people appear.
I love that. I think once you start sharing, the more open you are about the work that you're doing, it kind of can snowball. So I love that piece. We are a minute over, so I see some additional pieces coming in. I'm going to be sure to share the links and the resources here in the Academy space with our materials. And I'm going to pull up, if Shayla, you're okay pulling up our CEU information so we can make sure to get that over to folks. So we are going to pop a link in the chat here for CEUs. Those are housed on our Academy. Again, we will post the resources that folks have discussed, the slides, this recording in the Academy as well. I ask you to stay tuned for our next seminar session, which will be in September. And if we can go to the next slide, I'll just post you a quick little walkthrough of our CEU space on the Academy. So just noted, if you follow the link that Shayla put in the chat here, you'll come to our Rooted seminar series. Instead of clicking continue, you want to scroll down and find the July session, and then you can click through for the CEU request. Please follow up if you have any questions. Thank you again for your time, your interaction. Thank you, Nick, for such an engaging session, and I hope everyone has a wonderful rest of the day. Take care.